Hey everyone, welcome back to my channel. I'm Sheila G, the PAC, and today we're going to be talking about the most common form of eczema, known as atopic dermatitis. We're going to go over the clinical presentation, other conditions that are part of eczema, and of course, the treatment. For all things dermatology, don't forget to like, comment, and subscribe to my channel. Let's get right in. Atopic dermatitis is a chronic inflammatory skin condition that involves a dysfunction of the skin barrier, which leads to water loss in the skin. That results in dryness, itching, and a lot of inflammation. 95% of cases begin before the age of 5, as there are genetic factors that play a role in the development of the disease, and in most cases it improves by 8 years old. However, it can carry on into adulthood. Now, adults, although not as often, can suddenly develop atopic dermatitis, and when that happens, it may be a lot harder to control. Atopic dermatitis may be associated with asthma and allergic rhinitis, which involves frequent sneezing, congestion, and sore throat. When a patient does exhibit all three, we call this the atopic triad. When children have all three, it may be more likely to transfer into adulthood. Now let's go over how the disease actually develops and what's going on in the skin. Children who develop atopic dermatitis at an early age have higher levels of IgE in the blood. IgE is an antibody that is associated with allergies. Also, there is a mutation on a gene that encodes for what's called filaggrin protein. This is important because filaggrin protein is a very essential protein that is responsible for protecting the skin barrier and retaining moisture in the skin. So genetic alterations may decrease the amount of filaggrin that is produced, along with other essential proteins. There's also an alteration in the immune response, which leads to further inflammation and skin breakdown. There are substances called cytokines, and these are released from immune cells, and they contribute the most to atopic dermatitis. Specifically, interleukin-4 and interleukin-13 play the biggest role in the development of atopic dermatitis, and these are also the same factors that are involved in the development of asthma and allergic rhinitis. Now, for those who develop atopic dermatitis in adulthood, there are normal IgE levels, and there is no mutation on that filaggrin gene. Specifically, there is an overactivation of those cytokines, which contribute to inflammation and reduced essential proteins in the skin. We don't completely understand why that happens, but there may be some association with hormones and increased levels of stress. So when that skin barrier is compromised, we lose moisture as well as protection against external irritants, bacteria, and viruses. So children especially who have more severe forms of atopic dermatitis may be prone to superficial bacterial infections on the skin with Staph aureus. And when that happens, we call that impetigo. Now, impetigo involves a yellowish, greasy crust that develops over areas of compromised skin. Staph aureus specifically is a common bacterium already living on the skin. So we tend to see it show up in the form of impetigo when there is repeated scratching over those areas that are itchy and very dry. Now, the itching that happens in atopic dermatitis results from multiple factors. We have histamine that is released, proteases, and something called substance P, which all contribute to an abnormal amount of itching in the skin. And so that brings us to clinical features. What does it look like? Atopic dermatitis is a disease that starts with itching. We call that pruritus. So essentially, it's the itch that rashes. Now, the rash that we see in atopic dermatitis is a direct result of an itch-scratch cycle where a patient repeatedly scratches or rubs the skin, and that is either done consciously or subconsciously during sleep. The rash typically presents as red, inflamed skin with little bumps called papules. We may also see excoriations, which are directly related to the scratching. Now, over time, the skin is going to become a lot more thick with accentuated skin lines. We call that lichenification. There's also a lot of dryness because that skin barrier, again, is not retaining moisture properly. Now, atopic dermatitis typically presents in flexural surfaces. So, in between the elbows, behind the knees, the neck, the wrists, the ankles. But that can change depending on the age of the patient. Also, it can be everywhere. It can be generalized if the condition is more severe. But we'll go over those age ranges too and the differences between them. In the infant phase, which is up to 2 years old, atopic dermatitis more commonly presents on the cheeks and around the mouth, where there's a lot of redness and scaling. Also, it's very common in young children to get what we call lip lickers dermatitis, which results from habitual lip licking and saliva exposure on the skin and around the mouth. And that results in oozing, crusting, and severe dryness on the skin. In the childhood phase, between 2 and 12 years old, the atopic dermatitis primarily affects those flexural surfaces. And this is due to repeated bending, so flexion and extension, which produces heat and sweat. It's also common in areas of friction. We can also see atopic dermatitis in this phase affect the face, the hands, and again, in more severe forms, generally all over the skin. So the adult phase is when atopic dermatitis begins after 12 years old, and it can present in different ways. It can either be localized, so in one stubborn chronic area, or it can be generalized all over the skin, or again in those flexural areas. Now, it is more common though to see atopic dermatitis affect the eyelids and the hands in adults, as those areas are more prone to irritation and chemicals, allergens, things like that. Now let's go over some really common skin findings that are associated with atopic dermatitis. First is keratosis pilaris, or KP, which is essentially a condition where there's a buildup of dead skin cells in the hair follicle, and that can happen either on its own or more commonly in association with eczema. Now we see rough, dry, small red bumps on the skin, typically on the backs of the arms, the upper thighs, and even the face sometimes, and that can often get confused with acne. Now, the best way to treat KP is with ammonium lactate, which is essentially lactic acid that hydrates the skin. And that can be either prescribed or you can find it over the counter in forms such as amlactin. Next is pityriasis alba. This is really common in those with atopic dermatitis, especially children, and we can see this on the face, the neck, the arms, and it presents as round, faint, hypopigmented or white patches on the skin with a very, very fine scale. Now, what's important about this is that this is not permanent. This is temporary. A lot of patients and parents come in and they're concerned about vitiligo, but this is totally related to a dry skin condition. Children tend to outgrow this. Now, the biggest thing, the most important thing with this is to keep the skin very hydrated. Then we have something called prurigo nodularis. Individual lesions are called prurigo nodules, and these are very firm, round bumps on the skin that can either be hyperpigmented, a little bit dark, or skin colored. Now, this is more common in adults and can happen along with atopic dermatitis or in other clinical settings. Now, prurigo nodularis is directly related to repeated scratching and rubbing on the skin. And so it's more common to develop prurigo nodularis in something like atopic dermatitis that's already very, very itchy. Now, prurigo nodules can be pretty stubborn to treat, but we can use topical steroids, we can inject steroids directly into the nodules, or we can treat them with a common biologic that's also used to treat atopic dermatitis called Dupixent, but I'll get into all of that in the treatment section. Before we get into the medical treatment of atopic dermatitis, let's go over a few very important skin maintenance tips to practice at home. The first thing, which I'm very annoying about to my patients, is to avoid long, hot showers and repeated washing of the skin. This is extremely important because constant hot water exposure and repeated washing of the skin further strips the skin of its natural moisturizing proteins, leaving the skin a lot more irritated and dry. And that's already a chronic issue in those who have atopic dermatitis. So it is really important to cut down on the time and the temperature when bathing. The next thing is keeping the skin hydrated with emollients. The best time to moisturize is actually right after bathing when the skin is still damp, so that you lock in that water before it evaporates and pulls out the moisture with it. So I recommend for atopic dermatitis lotions or emollients that do not contain fragrance, that contain ceramides, which are proteins, and I also recommend those that have colloidal oatmeal, which is very moisturizing and soothing to the skin. Some of my favorite brands for eczema-prone skin include Eucerin, Vanicream, Lubriderm, and Cetaphil. Now for very, very dry skin, lubricants that contain urea or lactic acid are extremely hydrating. There are also some good over-the-counter body washes that are available, again, through Eucerin, Lubriderm, and Aveeno. Try to avoid any products or exposures that are known irritants to the skin. So perfumes, certain makeup products, chemicals, and cigarette smoke serve as irritants that can induce a flare-up of atopic dermatitis. Now, a lot of patients assume that they're just allergic to everything, but that's not necessarily true. In atopic dermatitis, the tolerance for irritants is much lower because of that dysfunctional skin barrier. So it's important to note that this may not be a true allergy, just a lot of irritation. Now, true allergens include house dust mites, pollen, molds, and pet dander. It's also very important to know that in infants and young children, food allergies can induce a big flare-up of atopic dermatitis, so food allergy testing may be necessary to know what to avoid. Now let's move on to the medical treatment of atopic dermatitis. How we treat the condition really depends on the age, the severity, the body location, as well as the response to previously tried treatments. Now, for active inflammation, it's very common for us to use topical steroids, either in a cream or an ointment form. Topical steroids really help to reduce inflammation. Now, there are several strengths of topical steroids, and the one we choose, again, depends on the severity, the age, and the body location that we're treating. So in children, we more often start with low to mid-strength topical steroids, which can safely be applied twice a day for about 2 weeks on and 1 week off. Now, for more sensitive areas of the skin, so the face, intertriginous areas such as under the arms, you want to use something that's a little bit lower potency, because what can happen is atrophy. Atrophy can be a result of chronic, continuous steroid use that's used incorrectly without taking a break. And it's essentially where the epidermis thins out. So you have thinning of the skin. So to avoid that, you want to choose a steroid that is lower potency, and you want to instruct the patient to use it correctly. So for a short period of time and then take a break. But we do have other topicals that are non-steroidal anti-inflammatories that can be used to treat these more sensitive areas without that risk of atrophy. So non-steroidal treatments that are topical forms include calcineurin inhibitors, so pimecrolimus and tacrolimus, as well as crisaborole or Eucrisa, which is a PDE4 inhibitor. For older children and adults, we also use steroids, usually in these cases mid to high potency steroids, again depending on the location and the severity, or we can use other anti-inflammatories that are non-steroidal. For patients that have secondary bacterial infections, we may prescribe topical and more often oral antibiotics to control that. Antihistamines may also be used either over-the-counter forms or prescription strength to control a lot of the itching. Now, more of our prescription forms, such as hydroxyzine, those antihistamines are more sedating, so they make you very tired. So we only recommend to use it as needed before sleep. Oral steroids may be used temporarily for those who have severe atopic dermatitis that has not responded to those traditional topical treatments. But there's other things to consider. Does the patient have diabetes? Because you can increase blood sugar. You have to keep some of those things in mind. But again, oral steroids such as prednisone are used temporarily and are tapered, and the dose is based on the age and the patient's weight. For children and adults who have tried and failed many conventional treatments, we do have biologic medications that are used to treat moderate to severe atopic dermatitis. Most notably are Dupixent and Adbry. Now, these biologics are injection medications that target those inflammatory cytokines that we talked about earlier that are involved in the development of atopic dermatitis. Now, Dupixent is indicated for ages 6 months old or above, and Adbry is indicated for ages 12 years old and up. Now, these biologics have slightly different targets, but they both target those inflammatory cytokines, so they're extremely effective at controlling and maintaining the skin clearance. The injections are administered either every 2 weeks or every 4 weeks, depending on the patient's age, their weight, and which biologic you're choosing. Now, Dupixent is also indicated for those who have asthma and chronic allergic rhinitis, also for those who have prurigo nodularis, so multiple indications. What's great about these biologics is that they're very safe and they don't require any lab monitoring, which is huge considering that a lot of our other biologic medications for things such as psoriasis do require labs. But it's always important to have a full discussion with your dermatologist regarding the safety and the side effect profile. Now, the insurance coverage of these medications really just depends on the plan that you have and previously tried and failed therapies. Now, there are some other treatments for atopic dermatitis known as JAK inhibitors, and there are oral forms and a topical form as well. The oral forms include Cibinqo and Rinvoq, and these are indicated for those who are 12 years old or older. Now, these do require lab monitoring as they do have some other potential side effects. So there you have it, a complete overview of the most common form of eczema, atopic dermatitis. I hope you found this video helpful. If you have any questions, feel free to leave a comment down below. Don't forget to like and subscribe to my channel for all things dermatology content. I'll see you next time.